Welcome to AETCM, the emergency medicine channel. Today let us discuss about ST segment elevation. We all know that ST segment in ECG that indicates ST segment elevation indicates myocardial infarction, ST segment depression indicate ischemia of the myocardium. But we will see other conditions also which can produce ST segment elevation and ST segment depression. Okay, so first of all, we will see what is ST segment. ST segment, you can see here, this is the ST segment. So you can see QRS complex, then ST segment, T wave. So this is the ST segment. S to T wave onset is ST segment. That is produced by ventricular systole in ECG. So whenever we are taking an ECG, ventricular systole produces ST segment. Normally that is in line with the PR segment. So PR segment is selected as the isoelectric line, or the ST segment should fall on that PR segment. You can see here the PR segment. So this is PR segment, QRS complex, then ST segment. All these things come on the same line. So that is important. So ST segment and PR segment come on the same line. If it is above that PR segment, that is ST elevation. If it is below the PR segment, it is ST depression. So there are two important problems which you can get in ECG when we are taking an ECG. It can be ST elevation or it can be ST depression. You can see here, basically ST segment is in an isoelectric line on the P wave, PR segment. Now you can see ST segment elevation means normally it has to come here and go like this. Now it is taking from here itself. So ST segment is elevated here. Here what you are seeing is just opposite that. It has to start from here, but now it has come down. That is ST segment depression. So ST segment elevation or ST segment depression is the most important problem in ST segment. Now ST segment elevation, most of the time what we have learned is ST segment elevation indicates myocardial infarction. It is not like that. There are a lot of other causes also can produce ST segment elevation. But as an emergency doctor, what we should understand is whenever we have a patient who is having any type of ST segment, like whether it is ST elevation or ST depression, even LBBB or whatever it is, if there is associated chest pain and elevation of cardiac enzymes, so symptoms has to be there, ECG has to be there, and you should have elevated cardiac enzymes. So troponin I, CKMB, for all these things are, you can call it as myocardial infarction. So pain may or may not be there sometimes, because in diabetic patients you don't get chest pain, but a patient can have myocardial infarction. But ECG changes are there in most of the conditions, and cardiac enzymes will be elevated in myocardial infarction. If the cardiac enzymes are normal and if there is ST elevation or ST depression, it can be something else, but that also indicates a myocardial ischemia. So here what you are seeing is the normal ST segment. Here ST is elevated, again ST is elevated, now ST has come down back to normal, now it has become completely normal. So normally in myocardial infarction, initially the ECG will be normal, and as the patient developing chest pain and symptoms, slowly you can see because of the myocardial injury, ST elevation occurs, then afterwards T wave inversion occurs, then deeply inverted T wave occurs. After some times the ST segment will come down and T wave will become normal. But if you are not thrombolizing properly, if you are not channelizing the coronary arteries normally, you can see that patient can have Q waves. So Q waves indicates chronic myocardial ischemia or infarction. So this one you can see the Q wave, then ST elevation occurs. In acute myocardial infarction, ST elevation occurs. Then after some times Q wave deepens and ST comes down, then T wave inversion occurs, or T wave inversion occurs during the ST segment itself. Then after sometimes deeply inverted Q wave can occur and ST may come down normal. So this deeply inverted Q wave always indicates a past myocardial infarction, and elevated ST always indicates an acute myocardial infarction. Now, when we talk about myocardial infarction, you can get ST segment elevation myocardial infarction, non-ST segment elevation myocardial infarction, even left bundle branch block also may indicate myocardial infarction. So, ST segment elevation above the J point, like you have some cutoff points like 0.01 millivolt in all leads other than V2 and V3. In V2 and V3 it is slightly different. The cutoff points are slightly different from other leads in V2 or V3. But whatever it is, as a general rule, more than 0.1, that is more than 1 small square SC segment elevation in general leads will tell you that the patient is having myocardial infarction or ST segment elevation. When it is associated with chest pain, when it is associated with elevated cardiac enzymes, you have to suspect myocardial infarction. And left bundle branch block, especially when it is a fresh left bundle branch block, it always indicates myocardial infarction. Normally, left bundle branch block alone indicates ischemic heart disease. If it is a fresh left bundle branch block, most of the time it indicates acute myocardial infarction. Now you can see here in this ECG, so this patient might have come with severe chest pain and sweating, bradycardia and all. You can see here ST segment is elevated in lead 2, lead 3 and lead AVF. Okay, so all these leads are inferior leads. Lead 2, 3 AVF, there is ST segment elevation. So that indicates inferior wall myocardial infarction. So that is very important. In inferior walls, if you are getting ST segment elevation, that indicates myocardial infarction. And you have to note here, in V1 and V2, there is ST depression. You can see here ST depression. That is a reciprocal change. That reciprocal change always occur when there is a inferior wall infarction. You get ST depression in V1, V2, whereas anterior wall infarction, you can get ST depression in inferior leads. So what you are seeing in this ECG is ST segment elevation in lead 2, lead 3 and AVF. That always indicates inferior wall myocardial infarction, and reciprocally you are getting ST segment depression in V1 and V2, V3. Now what you are seeing in this ECG is entirely different from what you have seen in the last ECG. Here you are seeing ST segment elevation in V1, V2, V3. So these leads indicates anterior leads. So you get ST elevation in lead V1, lead V2, lead V3. It all indicates anterior wall myocardial infarction. There may be some reciprocal changes here. You can see there is a small ST depression here. That all indicates reciprocal changes. It's not actually due to ischemia. It's a reciprocal change in what you are seeing. Because of acute anterior myocardial infarction, you are getting a reciprocal change here. So what we have seen in the previous slide is acute myocardial infarction in the inferior leads. What you are seeing in the current slide is acute myocardial infarction in the anterior leads. Now this is a lead placement, and depending on the coronaries you can get some changes. But as a emergency physician, you no need to know about all these changes, because what we are practicing is whenever somebody is coming to emergency room with chest pain, we always take detailed history. We take an ECG, and if there is an ST segment elevation or depression, if there is elevation of cardiac enzymes, then that indicates myocardial infarction. If there is no elevation in the cardiac enzymes, then it can be something else, or we have to do serial cardiac enzyme monitoring and see whether it is increasing or decreasing. Now depending on the leads, you can tell which area is involved, and you can also tell which arteries are involved. V1, V2 always indicates septal area, and it is due to proximal LAD. Like that we can identify all these things. 2, 3 AVF we have already seen, inferior leads, and it is mostly 90% is right coronary artery. That's why many patients with inferior wall MI can have bradycardia also, because the same artery is supplying your conduction system. So this other leads like V3, V4 is anterior leads, left anterior descending artery is involved. V5, V6 apical infarct and distal LAD and RCA will be involved. One AVL, again lateral leads, LCX is involved. Like that, you can see the ECG and tell which arteries are involved. But for an emergency doctor, these all things are nothing, because we are treating the patients with symptoms. We are treating for myocardial infarction. But for a cardiologist, when they are trying to do cath or something, they can understand which artery is blocked and they can go according to that. But all these things are not always exactly true, but we can pick up which artery is involved here. So again, we can know which all arteries are involved. Here, there is a ST elevation in AVR. That is very important. Normally, when we are taking an ECG, you don't get ST segment elevation. So ST segment elevation in AVR associated with multi-lead ST depression indicates subendocardial injury or demand supply mismatch. Other important things, the arteries involved here is left main coronary artery, proximal left anterior descending artery, and these are the important arteries involved. When there is an ST elevation in AVR, normally you don't get ST elevation. You know that AVR will be, all complexes will be negative here. So everything will be negative. But what you are seeing is, here is P wave is normal, QRS is normal, but there is ST segment elevation in AVR. Normally, in any ECG, including in myocardial infarction, you don't see any ST elevation in AVR, but here you are seeing ST elevation in AVR. So we have to think about left main coronary artery or proximal left anterior descending artery. You can see here some other leads got ST segment depression also. So what you do is, here we always ask for a troponin I or troponin T or CKMB. If you have doubt, you always ask for a cardiac enzyme if it is available in your ear, and depending on the value of the CKMB or troponin I, you can make a diagnosis of myocardial infarction. Otherwise, many ECGs you will not be able to, only with ECGs you will not be able to make a diagnosis of myocardial infarction. You always need to have a elevated troponin I or T or CKMB to make a diagnosis. Now, another important problem is Prince-Metal angina. What we have discussed in the previous slides is acute coronary syndrome, acute ST elevation, myocardial infarction. Myocardial infarction means the coronary artery is completely blocked, and after that coronary artery, wherever it is blocked, after that heart is not getting any blood supply, and that part is going to suffer ischemia and going to die. So that infarction is going to occur. But in Prince-Metal angina, it resembles myocardial infarction. ST elevation will be there, but it is only a transient ST elevation. During that period, there will be severe vasospasm. You can see here, vasospasm occurs. So if this is coronary artery, and suddenly severe vasospasm occurs due to some reason, and after sometimes, if you treat properly, this vasospasm will be relieved and patient will become normal. So the same thing occurs in myocardial infarction. Due to some reason, this part of the myocardium, this coronary is completely blocked, but it is not coming back to normal like this. Okay, so it's a fixed obstruction in myocardial infarction, but it is not fixed in Prince-Metal angina. So what you are seeing here is, so you get a ST elevation 1, so anterior lead, the lateral leads are involved, and you get a ST elevation in anterior leads like V2, V3, V4, V5. So anterolateral ischemia is there. So to know whether it is myocardial infarction or not, you have to give some time. You have to repeat the ECG. During this acute phase, patient has typical symptom of myocardial infarction, but after recovery, the ECG changes will come back to normal, and there is no elevation of troponin I or other cardiac enzymes. So this is called as Prince-Metal angina or vasospastic angina. Now, pericarditis is another condition. There is no coronary artery involved here. So you know that heart is covered by pericardium. So when the pericardium is inflamed due to viral fever or whatever it is, viral fever, tuberculosis, malignancy, whatever it is, when the pericardium is inflamed, patient can have typical chest pain. On auscultation, you can get cardiac rub. All these things are there. But a typical finding in ECGs, ST elevation in almost all leads. Wherever you see, there is ST elevation. So uniform and universal ST elevation is the classical finding you get in pericarditis. So pericarditis is a universal ST elevation. That is a classical finding, and if you ask the patient, will tell that I have chest pain for last 2-3 days, not acutely. If it is myocardial infarction, acutely patient will have chest pain. That is a main difference, and all the leads you are seeing ST elevation. That is the main difference between acute pericarditis and acute myocardial infarction. And this will not confine to any group of leads. Suppose it is anterior MI, V1, V2, V3, V4, V5 will be involved, and there will be ST depression in the lead 2, 3 AVF. That is not happening here. All the leads are involved. And remember one more thing, if you are asking for troponin I, CK and all, here also it will be elevated. Unfortunately, during acute pericarditis, myocardium also can be involved. So if you see the cardiac enzymes, you can make a wrong diagnosis. The CKMB troponin I also can be elevated in pericarditis, which is associated with myocarditis. But this uniform ST elevation is seen in pericarditis only. And one more important thing is, normally in myocardial infarction, what you are seeing is the concavity is towards down, but here the concavity is towards up. You can see here all these concavities towards up. So that is main differentiating feature, universal ST elevation, concavity towards upside. That is one important feature of pericarditis. Now ST segment depression always indicates some cardiac disease like ischemic heart disease, unstable angina and all. But basically there are three important types of ST depression: upsloping, downsloping and horizontal. What you are seeing here is upsloping. So suppose there is a rapid heart rate, you can get like this. There is a problem with the machine. Machine is doing it very fast, so it will not end up with a normal ST segment. All the STs are ST segment is depressed, and it is upsloping ST segment. That is very important. Whereas here it is downsloping ST segment. So here it is downsloping ST segment. Here it is flat ST segment. So this and this both are abnormal. This most of the time this is not abnormal. This is mostly rate dependent, and downsloping ST depression can be due to ischemia. This has to be due to ischemia only. Here it can be due to various other conditions like left ventricular hypertrophy, right ventricular hypertrophy, ectopic. All these things may be due to downsloping. It can be due to all these conditions. Now this is a rate dependent ST depression. What you are seeing is QRS complex, ST is depressed, QRS complex, ST is depressed. So this is a rate dependent ST depression. So when you control the rate with some drugs, or suppose it is due to fever, you give paracetamol, it will reverse back to normal. Now this ST depression is flat ST depression. You can get it, this depression is seen in V2, V3, V4, V5, V6, mostly anterolateral ischemia. So this patient is coming with severe chest pain, and when you are taking ECG and you are getting this finding, normally we ask for cardiac enzymes. If cardiac enzyme CKMB tropi is positive, then it should be taken as non-ST segment elevation myocardial infarction. If it is negative, then it is unstable angina. If it is negative, it is unstable angina. If it is positive, then it is non-ST segment elevation MI. Okay, so depending on the cardiac enzymes, we are going to make a diagnosis. Whatever it is, it's an ischemic heart disease, it's an acute coronary syndrome. If it is myocardial infarction, there is a complete block of the coronary. If it is due to unstable angina, it can be reversed back to normal with drugs. Now reciprocal changes we have already seen in myocardial infarction. Here what you are seeing, ST segment elevation in lead 2, lead 3 and AVA, lead 2 and lead 3. So it's an inferior wall myocardial infarction. What you are seeing in V1, V2, all these things are ST depression. So that is reciprocal change. Now, LVH and RVH also can produce ST depression. You can see very prominent R waves in V6, V5 and very prominent S waves, negative waves in V1, V2, and that indicates left ventricular hypertrophy. And in that ECG, what you are seeing is ST depression and T-wave inversion. So ST depression is also seen in left ventricular hypertrophy. Here, these ST segment depressions are due to demand supply mismatch. It's not actual ischemic heart disease, but in some sense it is ischemic heart disease only, because the demand is more, left ventricular hypertrophy is there, but coronaries are same. That's why you are getting ST depression and T wave inversion. That is a finding you get in left ventricular hypertrophy with strain pattern. What you are seeing is right ventricular hypertrophy with strain pattern. In that V1, V2 R waves are very prominent, and you are getting ST depression and T wave inversion in these leads V1, V2, V3. So that is right ventricular hypertrophy and ST depression. You are seeing a down sloping ST here. See, it is like this. So down sloping ST depression. So it can be due to LVH or RVH, and sometimes it can be due to ischemic heart disease. So we have discussed about acute myocardial infarction ECG finding, whether it is ST segment elevation or ST segment depression. But all these things depend on the cardiac enzymes. Remember one important thing, pericarditis, you get all these findings, but it's a universal ST segment elevation, and even CKMB or troponin I can be